going to present his potpourri challenges.
How do I start the play? Thank you, Sonal, for this wonderful opportunity. And thanks to all my colleagues. And thanks to AIOS. So this was a large macular hole in a pseudophakic eye, about 65 years age or so, and 61 years, and all appeared to be a simple, straightforward case. So I did the ILM peeling, and everything seemed to be going quite hunky-dory. I mean, forget some of those hemorrhages, they do occur in this age group of patients, and instead of a full-fledged reverse ILM peel, I just tried to massage the edges, and then I was doing base excision, and then this is what happened. The tip of the cutter, it got decapitated. So how do I remove the 25 gauge tip was then the next question. Do I change the cannula set, or what do I do? So I just went in with the 20 gauge MVR, made a 4th port, and just picked it up, removed it. I didn't think of putting the PFCL at that time because my heart was in my mouth. Anyways, I completed the base excision and continued with the 25 gauge vitrectomy, then did a fluid gas exchange, and then I put in silicone oil, air in the AC to prevent migration of the oil. And everything seemed to be going fine post-op, first post-op day, hole closed, but the saga continued. On the 24th day post-op, suddenly I find all these yellow-white dots, and I had no clue what it was due to. There was no AC flare cells, but just didn't know what this was due to. He gave a history of severe stress because his brother had an acute MI and he was in the ICU, and this guy visited the ICU. He also had a stray dog whom he had adopted and was looking after. So the first question was this due to some, the blast wave because of the cutter getting decapitated? But then why should it occur after 24 days? So the next thing is, are these small pre-retinal collections of small pus pockets? So gram-positive Cocci endophthalmitis, didn't know. I asked for an aqueous PCR. The patient refused any further investigations, started becoming aggressive. He was still seeing fine. He had no, and then he started dropping all the big names in the state and the city, And then I came to know that he was a leader somewhere and whatnot and whatnot. So anyway, with nothing to go forward, gave him linezolid, but spots continued to become confluent, though on OCT they were not raised as much. And he finally agreed to some blood tests, and the herpes virus thing was positive, so went ahead, gave him oral acyclovir. The spots started subsiding. Vision was still maintained around 624, so probably like an acute multifocal inner retinitis. Looked up some of these references, and could have been the virus, or I do not know whether the blast from the cutter itself would have introduced some bugs or whatever it was, but this is how things were progressing. And for till this was settled, I didn't want another intervention, nor did he, but eventually the spots had settled. But then he had some other systemic issues and whatnot. The oil removal got progressively delayed. So the saga still continued further, even after these spots had. So this was when the spots had appeared, and this was once they had cleared out. So these were those spots initially, and then in the resolving stage, and then eventually they had resolved, but they'd left behind some inner retinal defect. So then finally oil removal was done. Oil had started emulsifying, so there were emulsified bubbles in the AC. And this is one step just for the novices, that when you want to introduce a brush backflush needle or a DDMS scraper, you need to remove the valve, otherwise it might get stuck in the cannula. So there was this flimsy membrane, as was seen pre-operatively in the OCT also. One more thing for the new vitreoretinal surgeons, to break the flow to prevent a new macular hole getting created by the gush of pressurized infusion. So for these flimsy membranes, I mean, the DDMS would be the way forward. And triamcinolone, again, our good old trusted friend, which helps us to delineate the membranes, and a lot of patient scraping with the DDMS. Because otherwise, these fibrinous membranes, they have the potential of creating new breaks at the macula. And I will show you in the pre-SOR picture of the OCT. I was suspecting, in fact, whether the hole had opened up. Now, incidentally, we'll come to that later. At the end of what I thought I had finished the oil removal and was ready to close, the view had become suddenly hazy. And it was because of this oil bubble from the vitreous base region suddenly would have come through the zonules and had come into the anterior chamber, which one would not have noticed normally. I mean, it was all going hunky-dory and one wanted to wrap it up fast. So one was fortunate to have noticed that, removed that oil bubble from the AC using viscoelastic, and then wash of the viscoelastic. That's also important to prevent secondary glaucoma. Now this appearance was there pre-operatively, sorry. I'll just go back to that. So before the SOR, so I was in fact wondering whether the whole might have given way, whether there was some tiny microscopic remacular hole formation and some oil bubbles might be, the screen's gone off, yeah, might be again, but then luckily it's all settled and it's okay. These are RP changes which are occurring. So that's the final thing, and patient has 624. And I've allowed him to go back to his village and off my head. Now here's another case. Previous high myope was operated for cataract and vision was. Can I finish this quickly? Vision was not improving. The cataract surgeon kept saying, no, it will improve, increased of, local steroids. Anyways, presented with hypotony, large choroidals, detachment and whatnot, and with early PVR. So anyway, vitrectomy, buckling, all that was done. Oil removal was done. He was doing fine. And then in the 3rd week post-op, I noticed some fluid over here. And the causative region was breaks which had developed in the on the posterior slope of the buccal. So anyway, I did a pneumatic. I injected SF6, positioned him, did laser barrage. Yet again, there was fluid, and the break was beyond this in the superior region. Luckily, we were able to again inject SF6. Laser off that entire area and salvage the situation. So sometimes our simple good old pneumatic retinopexies can also prevent a revitrectomy. Just wanted to. So thank you very much.
Thank you, Paritosh. Manish was just showing me one case, similar case that he had, and he just wants to show it. Show it to you all.
Hello. I think what Paritosh showed those lesions, I just remembered that I have something very similar. It's not on a PPT, so I'll just show you the photos that I have along with the. So this was a case which had come with it's a toxoproven case actually, which had come for surgery. This is post-op. I'll show you the pre-op. So he had developed an epiretinal membrane with an old treated toxo lesion prior to when he came to us, and he came to us with a membrane, and we'd operated him for a membrane removal. So this is the intraoperative status. I'll just fast forward quickly to show you the lesion which was there, and we removed the membrane, and you can see that this whole sheet over the whitish lesion was a thick plaque-like area which was removed, and the surgery was uneventful. And then post-operatively, he got back actually 6/6 vision. This was his macula. In spite of all those folds, everything cleared up. And then after a month, he came with the similar kind of inflammation, what Paritosh was showing. This whole spattered, although this one did not have oil or anything, but you see these small whitish lesions all over the place, aggregated in some strange manner. And we also didn't know what it was. The OCT showed them as all pre-retinal kind of deposits. They were not intraretinal, or they were not inside the retina. They were all pre-retinal deposits like things. So I think at that time we gave him again an anti-toxo with steroids, and he eventually cleared up. Not in a sequential order, but you'll see this is when he came with that fulminant, and then slowly the deposits got less and less over a period of time, and then totally cleared off at some point. But it reminded me of a similar pattern that you had. So